Sujit. She is a consultant radiologist in Basildon University Hospital. Anjali and myself, we have worked together on teaching projects since more than a decade, undergrad as well as postgrad teaching. So thank you, Anjali, because she was actually pushed by the junior doctors to do this. So hats off to the team. This is a Friday evening, and you are doing this, so that is absolutely brilliant. Anjali, some comments from you. Then I would like to just introduce DKT to the participants. I just want to tell them in about 5-10 minutes something about DKT. But your initial comments, please. Anjali, over to you.
Thank you, Dr. Khan. Thank you. And welcome all of you again to this DKT Radiology Masterclass series. So this Radiology for Medical Students, this series is the brainchild of Dr. Khan. And we have a big team of junior doctors who have helped us, supported us in organizing and coming up with this course. So a big thank you to all of them. Before we actually move on to the course structure and details, Dr. Khan would like to say a few words about DKT. Thank you.
Right. So just a few words about DKT, because DKT, as in Dr. Khan's teaching, is a forum or a platform in which we do teaching, which is FRCR level teaching. So FRCR is, of course, the fellowship of the Royal College of Radiologists, and that is the other end. So that is where we pitch our teaching, and today we are doing a very basic teaching on medical school teaching. So I just wanted to share with you that what is DKT. So my name is Sami Khan. I'm a consultant radiologist at Basildon University Hospital, also an associate lecturer at ARU, and I'm founder of this teaching platform, which is Dr. Khan's teaching. So what exactly is Dr. Khan's teaching? Dr. Khan's teaching is a volunteer organization consisting of passionate teachers whose mission is to provide free of cost, note this word, free of cost, quality radiology teaching to the radiologists of the whole world, according to the curriculum and guidelines of the Royal College of Radiologists, enabling them not only to obtain FRCR, but also ultimately help in delivering better patient care. So if we feel that if there are better radiologists in the world, there will always be better diagnosis. And in the end, who benefits? It's the patient who benefits. Look at this. This is our motto. We teach for the love of it. Simple as that. So this is just a breakdown of the same definition, and I just wanted to emphasize that this is a completely volunteer organization. We are very proud of this model. And of course, free of cost. So we teach it, and we really mean it when we say we teach for the love of it. Please remember, our teaching is pitched at a different level, which is the highest level in radiology to enable FRCR. But today, of course, we are going to teach at a very basic level. The message of DKT is very simple, which is team up to teach the whole world. Simple as that. And we have, our main ethos is that there should be what we call, we have to bridge the inequality in global education. So we think like this, that somebody who is sitting in London should be getting as, the teaching which he or she gets is definitely top of the world. But some student who is sitting in, let's say, Kenya, or let's say Sudan or Nigeria or India or Pakistan or Sri Lanka should be getting same kind of teaching. And this is what motivated us to start this forum. This is our team, and we have got a huge team. I'm very, very proud of our team. There are 60 consultants who are part of our faculty, and more than 100 junior doctors or medical students, or even radiologist, trainee radiologist, at times uh, qualified radiologists, they are part of our team. So it's a huge endeavor, because you will just realize that the amount of teaching which we do is a weekly teaching, and we do it completely. We are actually dependent completely on our volunteer team. So huge thank you to all of them. The idea to do this came to us because we have got a culture in Basildon of we have over the years, going back to 2006-7, we have produced many innovative teaching projects. One of them was a very famous international course by the name of Basildon A to Z course, going back to 2007. And we used to cover whole of the curriculum of radiology on 16 weekend days per year. And again, this was free. So when COVID came, in came this idea, and we went online. So Dr. Khan's teaching started online in June 2020. Right now, we have got members uh, from 122 countries, but because of historic reasons, Royal College of Radiologists fellowship, which is FRCR, is a dream fellowship for people who are, I call it the FRCR world. So this is the influence for historic reasons uh, of going back to the Commonwealth. So the Commonwealth countries, as well as in Middle East, Southeast Asia, there are, radiologists of many countries. They want to do, first of all, fellowship of their own country, and then a second fellowship, the RCR fellowship, and we teach them. Simple as that. So just to give you an idea that we have got so many members, UK, more than 2,500. Please remember, these are fellowship level members, who are doing fellowship or who were doing fellowship. Pakistan, 3,000 plus, India, 2,600 plus, Egypt, 600 plus, Saudi Arabia, 336, Nigeria, 303, Malaysia, 294, Sudan, 247, Kenya, 222, UAE, 221. So these are the top 10 countries. I always talk about Kenya a lot. In Kenya, there are 280 radiologists, and out of that, 222 follow our teaching. So what happened was that at the height of COVID, we started this, and we did, our course, which is A to Z course, for students sitting the 2B exam, sorry, FRCR 2B exam. It was a completely viral in radiology terms. 19,000 people attended it. This gave us the idea to formulate another course. This is a 2-year course. This was a 2-year course. We successfully delivered from 2020 November to 2022 December, covering whole of radiology. Since then, we also do many viva session or mock exam sessions, should we say. And after culmination of those courses, since 2023 January, we do our weekly sessions on Thursday, and then, sorry for that, and then we also broadcast pre-recorded sessions on weekend Saturdays and Sundays. So till now, these are our statistics. More than 12,669, members from 122 countries. This is the amount of teaching which we do, which have done 853. I think this is massive. A university will not do this kind of teaching, what we have done. Our attendance, usually in a session of DKT, which happens on Thursday, we usually get 400 plus students. Yesterday, there was a session in which 522 people came in. So our numbers are these are viral numbers in FRCR world, more than 123,000. So, DKT is now a internationally recognized organization. Any radiology conference in UK, may it be a Royal College of Radiologists conference or UKIO, which is UK Imaging and Oncology, SRT, which is Society of Radiology in Training, etc. These are national conferences. DKT is always invited to deliver sessions for the trainees. We have also collaborated for many projects with NHS England, with radiological societies of various countries like UAE, Pakistan, Sri Lanka, etc. And so the global impact which we have is unbelievably, massive. And we have got feedbacks, thousands and thousands of feedbacks, how we have affected people with quality teaching. And I don't have time to go through them. But what we have learned is that one of our aims was to sort of train people for FRCR exam. But now we realize that because of our teaching, what is happening is we are actually making difference in the way radiology is practiced. Look at this feedback from Dr. Sam, who is from Kenya, had his training and was posted to a peripheral hospital, 300-bedded hospital as a junior consultant. He was one and only there, and he did not know many things. For example, esophageal carcinoma and pancreatic carcinoma, the Rift Valley of Kenya has got highest rates of both of these. And as radiologists, we stage cancers there. We tell the surgeons if a patient is operable or not. But he did not receive that kind of teaching. And he says that he learned it from us and he's applying on the patients. So that is impact. And he also tells us that he had never been trained on MRI scan in his training. And then what happened was that the Kenyan government put up a zero point 0.5 Tesla, 0.3 Tesla MR, very, very basic MR for MR of the spine, rule out cord compression. And there was a telelink, and he did not know how to report it, but he followed our teachings. And this is how he is reporting MR spine. So we are creating a massive difference in the world. So with that small introduction about DKT, let's go back to today's teaching. As in the beginning, we have introduced that this is one first of the 9 sessions. We will cover chest X-ray, abdominal X-ray, and a bit of CT brain. So Dr. Anjali is going to lead this. So over to Anjali. Anjali, are you with us?
Yes, thank you, Dr. Khan. Thank you.
So I am going to stop share and you can please share your screen.
Sure. Thank you. And can you all see my first slide, which is the title slide, Radiology for Medical Students slide?
We can see it, but for the audience, when Anjali talks to you, you can answer in chat from now onwards. But Anjali, it is absolutely fine.
Okay, yeah, thank you. So what Dr. Khan has already mentioned, we have planned 9 live interactive teaching sessions across the next 3 months. There will be short breaks in between. We aim to cover essentials of chest X-ray, abdominal X-ray, and CT head during this 9-week course. The course structure is such that, so each session will have teachings, and in between we'll have short quizzes. So today, Dr. Rihanna, Dr. Sadia, and Dr. Zain, who are our foundation year doctors, they will be joining me for this session and will be taking care of the quiz component. Now, feedback is very important. So we request all of you to provide feedback. This is a feedback slide, which will be projected multiple times in between, and the feedback link will also be pasted on the chat window. So during this session, if you have any questions, you can type it up on the chat window, and either during a break time or at the end, we'll answer your questions. Okay, so what we mean by, what are the aims of this course? So we would hope that we hope to teach you the essential radiology interpretation skills for you for your exams, as well as for you when you become young junior doctors. We also hope to inspire more of you to learn more radiology to become future radiologists. So nowadays, it's not uncommon for you to end up in such a scenario that you may be the only doctor in the ward. Your senior doctor, your registrar, your consultant may be taking care of another patient in another ward. So you may be required at times to interpret a chest X-ray, a bedside or a portable chest X-ray, interpret it yourself, and then inform your senior, your findings. So just imagine I am the junior doctor on the ward, and my patient has now had a chest X-ray for chest pain. Let's see how I'm going to interpret it. Okay. So it looks like I'm having some serious trouble here. So no, this X-ray is just for is an exaggerated X-ray. Okay, so I'm sure none of us will end up in this situation, like holding a chest X-ray upside down to interpret. But the message is we need to be equipped with some essential skills of X-ray interpretation before we start as junior doctors. Okay, so before we start the session, there is a short quiz for you, and it'll be Dr. Rihanna who will be doing this quiz. Over to you, Rihanna. So this is the first question.
Thank you, Dr. Sujith. So for this part of the session, we're going to give you 20 seconds to answer each of these questions, and then we'll go over them afterwards, okay? So for the first one, you have 20 seconds. So having a look at this image over here, is this a normal or an abnormal chest X-ray?
Rihanna, I've moved on to the next question. Sorry.
Thank you for answering.
Yeah.
Thank you for answering in the comments. So this is the second one. So having a look at this chest X-ray, do you think that the positioning is adequate? And could you please comment on the rotation? Do you think it's rotated? Okay, and now looking at the third image over here, is there tracheal deviation? Please put your answer in the comment section below. All right, and having a look at this next image, could you please comment on if cardiomegaly is present? And in this next chest X-ray, could you please comment on the reasons why you think that it's technically inadequate? Over here, you can see that we have two chest X-rays. These were taken from the same patient and they were performed on the same day. Could any of you please comment on why you think they look different?
Thanks, Rihanna. That was the last quiz question, wasn't it?
Yes, it was.
Yeah, thank you. So we will come back to the answers to the quiz after we go through what we call as some basics physics of X-rays and the technical factors. Okay. So by the end of this session, you will be able to develop an understanding of normal X-ray appearance and assess the technical quality of a chest X-ray. And the latter part of the session, we look at two of the common chest X-ray pathologies, which is pneumothorax and pleural effusion. So a little bit about the basic physics of X-rays. Okay, X-rays are ionizing radiations, and they pass through human body and fall on what we call as the receptor, and that's when we get the X-ray. And when we look at the X-ray, what we see is there's a degree of grayness and whiteness depending on the tissue. Okay, so right here you can see a bright white structure here. So extremely white is usually metal. Okay, so the degree of density, it ranges from extreme white, which is metal, to extreme black, which is fat. Air, sorry. Okay, so after metal, you can see that bone is again white, but is not as white as metal. And then if you look at the center, the heart and the mediastinum, or you can see here, this is the hypochondrium, which shows the soft tissue density of the liver. That degree of whiteness corresponds to the soft tissue density, and it is lesser than that of bones. Before I show fat, let's look at air. Air is the black density within the lungs here. Okay, so if you look outside, this is sort of the subcutaneous plane. You can see there is a less black or a gray area. So that is how fat would look on X-ray. So subcutaneous fat or fat anywhere would look less black than air. So this is the range of densities that you will see, and your interpretation would a lot depend on the degree of whiteness or blackness that you see on an X-ray. Now, you have to understand the concept of radiographic positioning. Okay, so the basic views that we take for an X-ray are these. That is a PA view, or a postero-anterior view, which is taken with the patient standing, and a lateral view with the patient standing again. So the lateral view has got very few indications at present, but we'll look at the indications and how a lateral X-ray looks not today, in another session. But today, right now, we are going to look at the different types of projections that you can come across apart from the basic views. And we'll also describe why, we'll also see why PA view is called PA, and why the supplementary views are required, etc. So the supplementary views are a lot. Okay, so they have got specific indications. Whenever PA view is not possible, that is, patient is not well enough to stand up, and posture himself for a PA view, then we invariably end up doing an AP film. Okay, we'll see that. So a few other supplementary films are lordotic, apical, decubitus, expiratory, oblique, etc. So this is how a standard X-ray is taken. Okay, so you can see here that this is the X-ray tube. Okay, and this is the patient. Now, X-ray tube is at a fixed distance. Give me one moment. My slide has got some. Yeah. Okay. Okay, so you can see that X-rays pass through the posterior aspect of patient's body, come out through the anterior aspect, and you can see patient is hugging around something, right? That's the receptor. So the X-rays fall on the receptor, and that's how an image is produced. Okay, so that's why it is called a PA view, or a postero-anterior view. X-rays pass through the posterior aspect and come out through the anterior aspect. So postero-anterior or PA view. It's taken in the erect posture, and the tube to the film distance is fixed, that is 6 feet or 180 centimeter. And the patient has to hold his breath in a full inspiration at the time the X-ray is taken. So when all these 4 criteria are satisfied, we get a standard chest X-ray. Any deviation from any of it, the X-ray can have some changes, and you have to be aware of it before you interpret the X-ray as normal or abnormal. Okay, we'll look at all of that during this session. Okay, so and this is the resultant PA view of X-ray that we get, okay, from postero-anterior. So this is the PA view. So again, just a reminder, erect posture, PA view, tube film distance of 180 centimeter or 6 feet, and breath held in full inspiration. This results in a standard chest X-ray. Now, this is how a lateral view is taken. So you can see the patient is standing up again, and he has moved his arms up like that. That is to avoid bone and soft tissue overlap of both his arms across the lung fields. Right? So we just move on to just a brief look at the supplementary views. So when the patient cannot stand up to do a PA view, then the next thing is either he may have to sit down for an X-ray, or he may have to lie down. So in both instances, X-ray will be passing through the anterior aspect, coming out through the posterior aspect, and falling on the X-ray receptor. So that becomes an A standard X-ray. So there are other supplementary views, for example, decubitus view, where the patient lies down on his side and an X-ray is taken. It has got certain specific indications. For example, one indication is to demonstrate a very small pneumothorax. So you lie down with the abnormal or suspected side up, you lie down and you take an X-ray, and if there is a small pneumothorax, it would the air would go up to the most non-gravity dependent part, and you can see the lung would have fallen down a little bit. So these are all special instances. Okay, so nowadays to demonstrate a small pneumothorax, or if you have suspicion of a small pneumothorax on an AP view or on a frontal chest X-ray, you're not able to demonstrate a pneumothorax, means we are not going to spend more time on an X-ray. If you want to clarify, you go for a CT, but you have to know that these views are there and these are the indications. So this is an oblique view, so you get better views of the ribs there. And these are inspiratory and expiratory views. So just to show you the difference, on an inspiratory view, the patient has taken a very good deep breath, and all corners of lung, the lung volumes have opened up, the corners have opened up, and you can see a lung lesion here at the base. And look at the same patient in an expiratory view, what happens? The lung is not fully expanded. So there are corners which are not opening up, and that lung lesion gets masked. So this is the importance of having a good inspiratory film on a chest X-ray. Something more to show was the lordotic view. Lordotic view is again a special view. where this is how the patient is positioned. This is a special view to look at the lung apices in particular. So sometimes when we take a PA view, because there are a lot of bones overlapping your lung apex, like the anterior end of the first rib, anterior end of second rib, the medial end of clavicle, they all overlap. So when we are not sure, is there a lesion there in the lung, which are overlapped by the bones, and we are not sure, means we do a lordotic view. So it's positioned in such a way, and the X-ray beam is angled in such a way that you get a clear view of the lung apices with most of the bones or the clavicle moved away. Okay, so these are all supplementary views. Now we have a protocol to view X-ray. Okay, so we cannot miss out on anything. So anything that is seen on an X-ray has an explanation. If it is a density or a lucency, if something that looks white or something that looks dark, it will have an explanation. It will be either a normal structure or a pathology, or it may be artifactual, or it will be related to some of the technical variations. Okay, so anything that you encounter, make sure you give it an explanation before you close the X-ray. So all these structures we'll be seeing in detail during this series. And so first we are going to start with the technical markers. Okay, so technical markers, what do you mean by technical markers is there will be some, so technical factors include four mainly. One are markers. By markers, what we mean, on the X-ray, you will be able to see certain markers, certain labels, which will show you what the projection was. Sometimes if it is AP, you would have written, it would have been placed. That is, this is all manually kept by the radiographer. So a label would be there which says AP or AP supine or AP erect or AP semi-erect. Or if it is a PA view, most of the time, that label may not be kept. And we infer it is PA, okay? And there will be a side mark to show which is right and which is left, right? So the side mark that is how we look at an X-ray is how we want to look at a patient. So when I look at a patient, the patient's right side is on my left side. So that's how I want to look at the X-ray as well. Patient's right, the X-ray's right side corresponds to patient's right, and that should be on my left side, okay? So the radiographer would put a mark R on the right or L on the left. It's very important to look at this, and it's also very important to look at all the other labels. And the next one is adequate inspiration. And the next is whether the X-ray is centered properly or is the patient rotated to one side or not. And the fourth factor is if the exposure factor is adequate or not. Why are these technical factors important? It's because variations in them or inadequacy will impact the quality of the X-ray. So you may misinterpret some of the factors as abnormal, whereas it may be normal. Okay, or some abnormalities may be masked by variations in the technical factors. So before you start interpreting any X-ray, the number one thing that you need to do is look if the technical factors are adequate or not. We'll start with markers, okay? Sorry. So this is the marker R on the right side. So this is a correctly labeled X-ray, and I can see on this X-ray that the scapulae are wider away. It's not overlapping the lung fields. That's because this is a standard PA view, and the patient had kept his arms abducted away and had hugged around the receptor. So that the purpose of that position is to move the scapulae away from the lung fields. There is no other label on it, and so this is a PA view. Okay. So moving on to the other markers, so if you look at them, so this is a PA view we just saw. There is no other label on it apart from the side mark L. And you can see an AP erect label here. This is an AP view. This is a supine view. There is a marker supine here. There is a marker here which says supine. When it is a supine view, it is understood that it is an AP view. Okay, it cannot be a PA view. And here there is a marker, AP semi-erect. So all these markers, once you read them, the way you're going to interpret that X-ray is going to be based on the nature of the projection, or based on what you've read now, right? Just to show you the difference between PA and AP. So this is a PA projection, what we have seen now. This is the tube. The X-rays go through the posterior aspect, fall on the X-ray receptor. Come out of the anterior aspect and fall on the X-ray receptor. And this is the resultant PA view of X-ray that we are getting. Now, how is an AP view obtained? AP chest X-ray. So here is the X-ray tube. Patient lies down supine. X-rays pass through the anterior aspect, come out through the posterior aspect, and it has to travel a certain distance before it can hit the X-ray receptor. So what actually happens during that time is, can you see the X-rays are diverging? So once the X-rays come out of the patient's body, they are diverging a little during that, while they traverse that short distance. In effect, they are causing some magnification of the heart and mediastinum because of that distance. So this is why an AP X-ray has an inherent magnification of heart and mediastinum. That's why we do not mention or comment about heart size on an AP film. Okay, so it gives a false impression of cardiac or mediastinal or aortic enlargement. Or converse is also, if you think, if on an AP film you measure heart size, and if heart size is normal, then that means you are sort of excluding cardiomegaly. That part is clear, isn't it? So on an AP film, even in spite of the enlargement, when you measure heart size shows normal, means there is no cardiomegaly. Okay, so this is the same patient with an erect or upright PA view, and the same patient having a supine AP view. Okay, look at the difference. Look at how magnified the mediastinum, the heart shadow is. So that's why it's important to look at the nature of the projection. If we don't look at it, we probably might have ended up saying, okay, there is widening of mediastinum, the heart may be a bit enlarged, and we may measure and find actually measurements getting in favor of enlargement. But look at the projection and you should not comment about enlargement. Okay. Moving on. So we are now going on to the second technical factor, which is whether the patient has taken an adequate inspiration or not. So to look whether the patient has taken adequate inspiration, what we do is we count the ribs, either the anterior aspect of the ribs or the posterior aspect of the ribs. So what we should ideally get is the sixth rib, that is the fifth to seventh rib. The anterior aspects should intersect. This is diaphragm. This is clavicle. If you draw a line through the middle of clavicle, so this is the mid-clavicular line. So ideally, the sixth rib should be touching the diaphragm in the mid-clavicular line for it to be a good inspiratory film. So here we have labeled it, and we can see that this is the first rib, second, third, fourth, fifth, sixth. So it is sort of the sixth space that is intersecting diaphragm. So this is a very good inspiratory film. Okay. So if you're counting the posterior ribs, ideally the 10th posterior rib should be intersecting diaphragm in the mid-clavicular line. We have outlined the ribs, the posterior ends here. This is rib number 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So this is the 10th space that is intersecting diaphragm. So again, this is a good inspiratory film. So either the anterior 6th rib or posterior 10th rib. Okay. So that's how you assess for adequate inspiration. Now, does respiratory phase matter? Why is it that if adequate inspiration is not there, why should it matter? Because we've earlier seen when we saw the supplementary projections, when we saw inspiratory and expiratory view, we did see that a lung-based lesion, which was seen on a good inspiratory view, was not seen on the expiratory view because it was masked. So that is one downside of a poor inspiratory film. So shallow inspiration causes reduced lung volumes. So certain lesions can be masked, and that can result in some exaggeration of lung markings. So when the lung markings, which are actually widely spaced blood vessels, when they come crowded together, you might get an impression, is some consolidation happening? Is something more than normal happening? And also when the lung volumes are small, it gives a false appearance of, is there any cardiomegaly there? Okay, so these are the downsides. So on this X-ray, let's count the ribs. So this is the first rib, second rib, third rib, fourth rib, fifth rib. So the fifth rib is intersecting diaphragm in the mid-clavicular line, and it's not a good inspiratory film. It shows reduced lung volume. It shows some crowding of the normal lung markings here, and it gives an apparent prominent or enlarged appearance of the mediastinum and heart. And it's difficult sometimes to say, is something more happening here? Is there some consolidation happening here? Is there some early pulmonary edema changes happening here? Okay, so this is the downside of a poor inspiratory film. So now moving on to the third factor, you have to assess whether a patient is well-centered. So ideally, we want the patient to be centered well so that both sternoclavicular joints, this is the clavicle, this is clavicle, this is the spine of the vertebra, spinous process. So ideally, we want both sternoclavicular joints to be equidistant from the spine. Okay, so how do we assess that? We've outlined the spine here, we've outlined the medial end of clavicles here, and we measure the distance to the medial end of clavicles. They should be same, they should be equidistant for us to say there is no rotation. So on this X-ray, you can see the distance is less on one side and more on the other side. So there is rotation there, okay? So why is rotation important? Why is to understand that the patient is rotated? Why does it matter? It can lead to misleading appearances of tracheal deviation. So if the patient is rotated, then the trachea is going to fall on that side. And so it gives an appearance that trachea is deviated. And then it may give a false appearance of abnormal heart size. One side of lung hilum may be projected abnormally prominently. And sometimes there may be changes in the lung density. So because of asymmetry, one side lung may look more whiter or more blacker, and that should not be interpreted as pathology if you are aware that the patient is rotated. Okay. So this is a grossly rotated film. So look at that. This is markedly rotated. Look at the medial end of clavicle. It's almost here, where the medial end of clavicle of the other side is here. So look at, it's a markedly rotated film. And here there is a mild degree of rotation. Okay. So we are now coming to the last factor, that is exposure or penetration. So radiographic exposure, or what we mean by penetration, is these factors, you know, like the kilovoltage peak, the current, the milliamperage, and the exposure time, the time duration for which the current is applied. So that depends on the degree of blackness or whiteness of the X-ray. So the one that you're seeing in the center is of adequate exposure, while on the left side, you can see clearly that the lung fields are very black, and that is because of overexposure or over-penetrated. And on the right side, we can see the lung fields are more whiter or hazy or more dull, and that's because of under-penetration. So nowadays, we can manipulate images on PACS and correct the degree of exposure to a certain extent. But we aim to get exposure as how it is seen here. So when you look through the heart, can you see the outline of the spine? This is the outline of the spine here, the vertebrae. And through them, you can just sort of about see the outline of the intervertebral discs. Are you able to appreciate that? You're not able to very clearly see them, but just about appreciate the intervertebral disc. Whereas that's how we want to see an X-ray. Whereas on a over-penetrated film, the intervertebral discs will be very clearly seen. Whereas on an under-penetrated film, you probably are not going to make any differentiation between the vertebrae. The intervertebral discs will not be seen clearly. It's not difficult to identify an over-penetrated X-ray because strikingly looking very black. Under-penetrated would look very bright. So what are the pitfalls? So over-penetration, the film too dark, under-penetration, they both can cause errors because they can mask certain areas, they can mask certain pathologies. Okay, so like I said before, the digital imaging to a certain extent has helped to solve these problems. Now, a brief note about the quality of portable X-rays. Okay, so portable X-rays means portable X-rays are always a deviation from a standard PA view. So one, portable X-ray, we cannot aim to get a fixed tube to film distance. Like I mentioned before, the 4 factors that we need for a standard X-ray are PA view, erect position, tube film distance of 180 centimeter or 6 feet, and breath held in deep inspiration. So a portable X-ray is usually done when the patient cannot walk himself, bring himself around to the department for a standard X-ray. So all factors will be usually variant. All technical factors will be different here. See, this patient he cannot posture himself for an erect X-ray. It is a supine or a semi-supine or a semi-erect X-ray. So that will be an AP film. So that is again a deviation. He may not be able to take a deep inspiration. ITU patients most of the time will have some kind of issues, like he may have heart failure, he may have some lung infections. They may find it difficult to hold breath, take deep breath and hold. And the other thing is the tube film distance, which we can achieve to be a standard 6 feet in the department. You may not achieve here, you cannot achieve here, okay? So all these factors result in a very suboptimal X-ray. Usually, they are all non-standard or suboptimal X-ray. And we have to factor all this, the AP projection, inadequate inspiration, all these, and it may be rotated as well. All these have to be factored before you comment any pathology on a portable X-ray. Okay. So now we are coming back to the quiz. So this quiz was based purely on the technical factors. Now we have gone through the technical factors. I hope you will be able to understand or answer all the questions better. So back to you, Rihanna.
Thank you, Dr. Sujith. Thank you, everybody who contributed earlier on. It was great to see all of your answers. So we'll go over the questions again. So in this first X-ray, the question was it normal or abnormal? So if we have a look at this image, we can see that the wrong side has been marked. So if we look in the left of the film, we can see that there is a right, an R label placed, which shows that this is the right. So this is unusual and it has the potential to cause some confusion. We can also appreciate that the heart is on this right side of the image. So this is also unusual because we'd expect it to be on the left. So there are a number of reasons that this could have occurred. Firstly, it could be due to the radiographers placing the marker on the wrong side of the image, or it could be a case of dextrocardia. So it's important that we investigate and find out why this happened. Looking at both of the options, it's more likely that this is due to the marker being placed on the wrong side. However, it would be good for us to compare this with any old images they have. So what we would do is look at the old X-rays and we would check to see if the correct position has been marked. That is that the left label is on this side as opposed to the right side. And if we do find that this is the case, that is a simple case of the wrong label being put on the wrong side, it's important that we clarify this with the radiographer and that we include this in our report so that everybody is aware. So the key takeaway from this question is to make sure that we're looking at the markers of each of the X-rays. So moving on to the next one. Over here, we're asking, the question was, is this positioning adequate? So if we have a look at this, we can see that this chest X-ray is showing that there is some rotation. So as Dr. Sujith told us earlier, when we're assessing rotation, we need to have a look at the spinous processes. We have to have a look at the distance between the spinous processes and the medial ends of the clavicle. So if we look at this image, we can see that the distances aren't the same. So what this tells us is that there is a mild rotation. And then in this next image over here, the question was, is there any tracheal deviation? So it's important when we're assessing if there's any tracheal deviation that we're making sure that the image, there isn't any rotation, because this affects our ability to interpret the image correctly. So as we can see over here, this chest X-ray is markedly rotated. And like I said earlier on, we can tell this due to the distance between the medial ends of the clavicle. And if we have a look at the right side, we can see that the distance is greater than that on the left. And because of this, we can't comment on the tracheal position. Also, another thing to note that we can see the lucency of the trachea over there. Okay, and for this one over here, the question was, does this chest X-ray show cardiomegaly? So if we have a look at this image, we can appreciate that it's a supine AP chest X-ray. Another thing for us to also notice is that the inspiration is inadequate. So the way that we assess for inspiration is adequate is by counting the number of ribs, so both anteriorly and posteriorly. So in the anterior, we would expect the sixth rib to intersect the diaphragm at the mid-clavicular level. But if we look over here at this image, we can see when we count the ribs that it's actually the fourth rib which is intersecting the diaphragm at the mid-clavicular level. So what this tells us is that the inspiration is poor. If you were to count the posterior ribs, you'd expect this intersection to happen with the 10th rib. So because of this, it gives an impression of cardiomegaly, but this is misleading because the inspiration is poor. Now, so for this image over here, the question was, why is this chest X-ray technically inadequate? So can you appreciate that when we're looking at this image, we can see that the lung fields are very dark, so they appear very black. So if we were to look through the cardiac shadow, we can also see that the intervertebral discs, they can be seen quite well. However, as we discussed earlier, we should only just be seeing them. So this image shows that there is an overexposure. So it's an overexposed or an over-penetrated film. And there are some downsides to films such as this, and one of them is that it can mask certain pathologies. And then the final image. So in these two images, we can see that there are two chest X-rays. They're done on the same patient on the same day. However, they appear different. So the reason that this has occurred is because, as you can see, the first X-ray is a PA one, whereas the second one is an AP. And the way that we can tell this is because of the marker. So if you look at the image, you can see that it says AP erect in the top right of the second X-ray. So when it comes to PA and AP X-rays, we need to remember that AP films have an inherent magnification of the heart and the mediastinum. And as a result of this, they look different to the PA films.
Thanks, Rihanna. I think that was the last one of the quiz answers, right?
That was,
Thank
you.
So we have sort of completed the technical markers, and the next part of this session, we would be looking at the pleura and pleural pathologies. So for all other sessions, we will go in the order, but just for today, we are starting with pleural pathologies, okay? So we will take a short break of 5 minutes, and then it's 18:57 now, so say 7:05, 5 minutes past 7, we'll start again. So I've just projected the feedback slide for you. If This is just to remind you of feedback. Please don't forget feedbacks. Okay, so we'll resume session again at 5 minutes past 7. So welcome back. So we'll resume the second half of today's teaching. So we are now going to look at the anatomy of a chest X-ray. We've done with technical factors. We're actually going to look at a chest X-ray and going to assess it. So only if you know the normal, and only then you can recognize the abnormal, isn't it? So so this is only if you know the anatomy and a basic pathology, only then you will be able to interpret the radiology correctly. Okay, so it's very important to go back to understand the anatomy and to learn some essential basic concepts before we start interpreting pathology. Okay, so we are going to look at the anatomy. So this is an X-ray, and we know that the chest X-ray shows two lungs on the either side, and the center part, which looks whiter or denser, is the mediastinum, including the heart. Okay, and both sides you have the diaphragm, the right dome diaphragm. This is the left dome diaphragm. So anytime have you wondered why the mediastinum and the diaphragm are getting a border? So the mediastinum is getting a border, the diaphragm is getting a border. Okay, so that is because of the contrast between the soft tissue density and the black air next to it. So in other words, if a structure on the chest is outlined by air next to it, if air comes to lie next to a structure, then the outline of that structure will be seen clearly on the X-ray. And that's why we are seeing the upper surface of diaphragm clearly, but we are not seeing the undersurface of diaphragm on an X-ray because there is no air under diaphragm. Okay, so, and that is exactly the reason why you are seeing borders of mediastinum and heart, because there is air on either side of the mediastinum. Okay, so understand this concept that structures get a border or outline because there is air in the lung next to it, because this forms the basis of an important concept and identification and localization of certain pathologies on X-ray, which we will discuss in the later sessions. Okay, so if you look, just to briefly show you, so when we interpret an X-ray, is either from center to periphery or from periphery to the center. Okay, so you can decide your own format. I personally prefer to go from the center to periphery. So whatever format you are using, the message is you should not miss out on anything. So we look at trachea, this lucency that's marked outlined is trachea. Then you look at the mediastinal contours. So we have the aortic knuckle here. The small area here is formed by the pulmonary trunk many times. You won't see it as convex like this. It will be just a concave area. And you have the left heart border. You have the right side of the heart, the right heart border. This part is the superior vena cava, and so we assess the mediastinum, and then we go out, and so we assess the cardiophrenic angles, this is the diaphragm, and the end, this is the other diaphragm, and the end in the costophrenic angle, and we come back to assess the lung hilar, and then we move to the lungs on both sides. You know, there are 3 lobes on the right and 2 lobes on the left. We'll discuss in detail how to assess lung in the coming up session. So it's just a basic idea of what we are seeing on the chest X-ray. So this is the lung hilar, which gives out branching vessels to both sides and the black air within lung. Okay, and then we move out again. We shouldn't be missing out on anything else. I mean, so we look for the soft tissues of the chest wall, all these soft tissues of the chest wall. We also look below diaphragm, the soft tissues under diaphragm. And then on the left side, below the diaphragm, you have the gastric air bubble. All this will be discussed in detail during the later sessions, but this is a quick overview of a chest X-ray, right? And then finally, we look at the bones. Each bone, each rib from the anterior, lateral, and anterior aspect should be individually traced on both sides. Don't forget your clavicle, part of humerus, and part of scapulae that you're seeing. So, okay. So, and remember to look through the mediastinum at the spine to see if there is any abnormality there or not. Okay, so in this session, we are going to focus on pleural spaces and pleural pathologies, right? So before we start pleural pathologies, let's have a look at the anatomy of normal pleura. So pleura is actually a serous membrane, which is composed of mesothelial cells. It's got two layers. As you know, it's got an outer parietal layer and an inner visceral layer, okay? So depending on where it is, it's named as, this part is the cervical pleura, that is at the upper part. This part is the mediastinal pleura. What outlines the diaphragm is the diaphragmatic pleura, and the rest of it is the costal pleura. Okay, if you look here, the space between the parietal and visceral pleura is the pleural space. It is a potential space. It's got about 5 to 15 ml of fluid, which you normally do not see on any imaging modality. On an X-ray or an ultrasound, the normal fluid for lubrication, you are not going to see on any modality. Okay, if you look a closer look again, you can see that on the right side, the visceral pleura alone goes into the lung and comes out. So that forms the minor fissure or the horizontal fissure. And here you can see, again, the visceral pleura invaginates into the lung and comes back. So that is the oblique fissure. And you can see the oblique fissure on the left. So only the visceral pleura takes part in forming a fissure. So if there is fluid filling up the pleural space, you can understand that it's easy for fluid to go inside a fissure. So we'll see that when we learn about heart failure or pleural effusion, that fluid can go into just the fissure alone and stay there and look like there is a encysted or a loculated kind of fluid within the fissure. So it's because of this. It's the visceral pleura alone that takes part in forming a fissure. Okay. So on an X-ray, so this is what we call as the cardiophrenic angle. This is the left cardiophrenic angle, and these are the costophrenic angles, the right and left costophrenic angles. These have to be sharply defined, okay? And this is the approximate position of the horizontal fissure. So usually you don't see fissures on an X-ray. So the oblique fissures are not seen on an X-ray. At times, on some of the X-rays, you may see part of the horizontal fissure. So the approximate position on an X-ray is, it approximately from the level of the hilum, it goes outwards and slightly down to intersect the sixth rib. So that is the approximate level of the right horizontal fissure on an X-ray, okay? So now this X-ray is just to show you the distribution of pleura. Sagittal means it is from the side. It is a side view, okay? So it's from the side. So just to give you an orientation, this is anterior and this is posterior, okay? You can see this is heart. Heart is in the middle to anterior and this is posterior, okay? And what you are seeing here is part of the oblique fissure. And what you're seeing here is all the upper lobe, left upper lobe, and this is all the lower lobe. Now, the purpose of this slide is to show you that, so whatever is outlined in the green is the outline of lung, and whatever is outlined in blue is the outline of pleura. So you can see that the pleura anteriorly, it just comes down, it reflects lower, it's quite low, ends lower than where the lung ends. Okay, it's important to have this concept in your mind. And when you compare it with the posterior aspect, you can see the lower lobe, which is outlined in green, ends here, and can see the posteriorly pleura even dips even lower down. So this is the most dependent part, right? So the importance to know this is, if a pleural effusion starts, if it's just confined, it will be starting in this posterior most dependent costophrenic angle. And you may not see that small tiny effusion on an X-ray. Okay, but you will be able to see that on an ultrasound scan. So this concept is important, that posteriorly, the pleura both anteriorly and posteriorly dips further down than the lung. And posteriorly, we have the pleura to be extending even further down to be the most dependent part. Okay, so a pleural effusion starts first here as it is the most dependent part. Now, this is an X-ray just to show you. Are you able to appreciate a fine, thin white line here? This is how a horizontal fissure can be seen on an X-ray. So we have just highlighted it with a brighter line just so that you will be able to appreciate it better. So if you see a line like this on an X-ray, then that is the minor fissure. Okay, no other fissures will be seen on an X-ray. Now, this is just to show you an incidental finding, which is a congenital appearance. You may see that on some X-rays. It's not a pathology. This is because an abnormal course the azygous vein takes. Okay, we're not going to go to the details, but this is how it looks. This looks like a fissure, and it is called an azygous fissure. And this is the position, okay? At its inferior end, you will usually see a brighter or a thicker white denser area, and that corresponds to the azygous vein. Now, this is not to be mistaken for any pathology. This is for you to understand that this is a congenital variant appearance, and you don't have to do anything for that, okay? Now, before we start pleural pathologies, we have again a quiz for you. And over to you, Sadia, for the first question.
Thank you, Dr. Sujit. So much like the first quiz, we're just going to give you some questions, 20 seconds, and then we'll go over the answers after Dr. Sujit has her teaching component. So for the first one, a 25-year-old male presents to the emergency department with sudden onset chest pain and shortness of breath following a minor fall. And you have 20 seconds just to have a look. And if we can move on to the next one. And scenario 2, so imagine you are the FY2 in A&E. A 22-year-old boy presents to A&E after being stabbed in the chest with acute shortness of breath and hypotension. So what is the diagnosis and immediate management? And now we'll move on to number 3. So a 28-year-old female presents with chest pain and dyspnea. Is this chest X-ray normal? And then the next one. Is there a pneumothorax here? And again, you have 20 seconds. And now the next one. Is there a pneumothorax here? And Dr. Sujit, if we can have the next slide. And then back to Dr. Sujit.
Thank you, Sadia. So that was the last question of the quiz. So we are moving on to the first pleural pathology, pneumothorax. Okay. Sorry. So by definition, what we mean is presence of air in the pleural space. Okay, so before we go to any other details, just one emergency condition we'll just describe first. So what is tension pneumothorax? Tension pneumothorax is an emergency. Okay, so that is when air constantly collects within the pleural space. It just keeps continuously collecting. So when the volume of air inside the pleural space enlarges, it just makes the lung to collapse. The lung collapses and it just pushes everything in its way to the opposite side. So the mediastinum, the trachea, the heart, everything is pushed to the other side, and it can cause depression of diaphragm. It'll cause so much of compression of mediastinal structures, leading to decreased venous return. Clinically, the patient may be having engorged neck veins here, and it is a life-threatening situation. Okay, so just wanted to highlight pneumothorax, tension pneumothorax before we are going into the details of generally about pneumothorax. So there are several causes. Primary or spontaneous is the more common one, where you don't have an underlying lung disease. And you can get secondary spontaneous pneumothorax when we have when there is an underlying lung disease. Okay, and the other causes include iatrogenic or traumatic, like following a biopsy you can have, following ventilation, following a central line insertion, pulmonary laceration, or say a pacemaker insertion. So any intervention can lead to accidental rupture of pleura, resulting in a pneumothorax. So radiological findings are, when we looked at the anatomy, we saw that there is a potential space. It's a potential space. Both the visceral pleura and parietal pleura oppose each other, and you don't normally see the pleural space on an X-ray. So when this pleurae, visceral and parietal pleura, separate because of air within them, then what happens? The parietal pleura stays along the inner aspect of the rib cage, whereas the visceral pleura moves inwards. So what we see actually is a thin white line of visceral pleura, just like how you saw the minor fissure. Fissure is formed by visceral pleura, isn't it? So similarly, a thin white sharp line of visceral pleura you will see. Okay, and beyond that, that is between the visceral pleura and the chest wall, it will be a black translucent area where you will not see the lung blood vessels extending. So that these two factors you have to see to call it, before you call it a pneumothorax. No, associated findings can be, depending on the volume of the pneumothorax, the underlying lung may be forced to collapse. Sometimes if it can be associated with surgical emphysema. Surgical emphysema means air within the subcutaneous plane, okay? Or where within the pneumomediastinum, air within the mediastinum, which is called pneumomediastinum. These are possible associated findings. Now, again, coming back to tension pneumothorax again, is there will be signs of tension. The signs of tension are because of the increasing volume of air in that pleural space, which will result in contralateral mediastinal shift, depression of the same side diaphragm, and sometimes if you look carefully, you might even see that the intercostal spaces on that particular side may look slightly more widened than on the other side. Okay. So we have a few examples of pneumothorax here. So this is a right-sided tension pneumothorax. So you can see the entire right hemithorax. You don't see any lung markings here. Usually the branching linear blood vessels you should be seeing. So this entire thing is pneumothorax. And do we have signs of tension here? We do. Look at the diaphragm. The diaphragm has been pushed down. And look here, the heart, which should have been sitting over the spine, it has been pushed to the other side. So if you look here, you can see some blackness or some lucency extending over the midline spine. This is all because of the increasing volume of air within the right side, okay? And the right lung is now compressed to such a small structure that it is just this. The compressed, collapsed right lung is just this, okay? You can see part of it here as well, right? So everything is pushed to the other side. So what happens is on an erect X-ray, when the X-ray is taken in the erect posture, the pleural air rises up, isn't it? And you'll see the visceral pleural line. This is the sharp white visceral pleural line separated from the chest wall. And this zone of lucency will not have any lung markings, right? Now, we have certain mimics of pneumothorax, certain conditions which will mimic pneumothorax and can create confusion. So like I discussed when we started, that any density or any opacity or a lucency on an X-ray has an explanation. It may be either a normal structure or a pathology, or because of some changes to the technical factors, or due to some artifacts sitting on the patient's body. So if you look here, you can see a curvilinear line, sort of a band-like density extending from the top to bottom of the lung. So now it looks very different to the thin, white, crisp line of pleura that we have seen till now. So I'm just going back to one slide back. So this is what you expect to see in pneumothorax. This is how visceral pleura should be seen. Coming back to the slide, this doesn't look like thin, crisp, white line. And if you look carefully, you can see lung markings are going beyond the level of this structure. So that means this is not pneumothorax. This is an artifact which we can see not uncommonly. We can see this because of external skin folds. Okay, so in ITU patients, when it is not a well-centered X-ray, when they're moving, or in babies, again, when we are not able to get a proper centering, and in chubby babies, when there is rotation, you can get this artifactual appearance because of skin folds. Same thing on this X-ray as well. So here you can clearly see that it doesn't explain, it is just going across over to the midline, and can clearly see the lung markings outer to it. So remember, this appearance is not pneumothorax, this is skin fold. It's not uncommon, or it's not common, but once in a while, we do receive phone calls from ITU when the ITU clinicians, when they review as X-ray of this kind, they are in doubt, is there a pneumothorax? And the patient is stable, doesn't show signs of pneumothorax. So they give us a call to clarify what is it actually. And then, so it's all clarified, it's a skin fold, no pneumothorax. So the only finding here is the right costophrenic angle that we saw earlier is not sharp. So this patient has a small pleural effusion, okay, which we will discuss in the section of pleural effusion. So I hope this concept is now clear to you. So this was again to show you, again, the crisp white line of pneumothorax. This is an X-ray. Again, acutely tachycardic, hypotensive, and the patient is desaturating. So you can see that this is the collapsed lung here. The lung is completely collapsed by a large right-sided tension pneumothorax. Can you see any lung markings beyond that? No, there are no lung markings. This is fully expanding air. And this tube here, or the line here, or the drain here that you're seeing here is a drainage catheter that has already been inserted to relieve the tension. But that tension has not been fully relieved. You can still see that the mediastinum has been pushed to the other side, and the same side diaphragm has been depressed. It's been depressed. Okay, so these are the signs of tension. So this is a case of large bilateral pneumothorax, and you can see both sides lungs are completely collapsed, and both sides diaphragm, they are depressed. So there's a bilateral tension pneumothoracis. So this patient should not have had an X-ray. So the treatment is immediate decompression. You immediately do decompress the excess air and relieve the compression. Okay, so This is just to show you how repeatedly we are showing the films of tension pneumothorax so that it stays in your mind. So large volume of air in the hemithorax, completely compressing the lungs, collapsing the lungs, and look at how narrow the mediastinum and heart has become. It's compressing the mediastinum, and that's what will result in reduced venous return. It is compressing the venous structures as well. Okay, so tension pneumothorax and emergency. This is a pneumothorax on the right side. We can again see a drainage catheter is there. But here there are no signs of tension. So this is a large pneumothorax, but the diaphragm is not depressed. Mediastinum is not pushed. It's in the center. But we can see it has collapsed the lung because of the volume of air in the pleural space. But it's not constantly increasing, and there are no signs of tension here. Or probably tension has been relieved by the drainage catheter. Okay. So we move on to something else. So now we come to a concept, pneumothorax in supine projection. So until now, we were looking at X-rays where air had freely risen to the top. But when the patient is lying down, pneumothorax, free air in the pleural cavity would have a different distribution, okay? On this X-ray, we are actually seeing a pleural line here. But if you notice, you're also seeing a deep tongue-like right costophrenic angle. Did you see that? Okay, and there is more of blackness or lucency over the right hypochondrium, and the right dome of diaphragm is very clearly outlined. So these are the signs that we see on a supine X-ray on pneumothorax. Let's clarify the concept, okay? So look here. This is the distribution of air in pleural space on the erect X-ray. So the air rises to the top. Maximum will be at the top, okay? When you lie down, what happens? The non-dependent part or the non-gravity dependent part in the lying down position is anteriorly, medially, and inferiorly. So when you're in the supine position, the free air, the air within the pleural cavity, that is pneumothorax, it will move to its new non-dependent position, okay? So it will come to the inferior, anterior, and medial aspect, outlining the structures in that area better. So that's why we are seeing a deeply outlined costophrenic angle. This is called a deep sulcus sign. And we are clearly seeing the outline of right dome diaphragm. If this was adequately positioned X-ray, then you would have seen the right heart border also would have been clearly seen. Can you appreciate the increased blackness or lucency over the right hypochondrium or over the liver? That is because the anterior, we saw the pleural reflections when we saw the anatomy, the anterior pleural reflection dips quite lower down to the anterior costophrenic angle. Okay, the anterior. So have this appearance in your mind. The deep sulcus sign, increased lucency over the right hypochondrium, because these may be the only signs that you may see when a patient is supine. You may not always see a clear pleural line. Okay, so this is another patient, again pneumothorax on the supine position. You can clearly see there is a well demarcated lucency under it, and the right dome diaphragm is clearly defined. Give me one moment to move this, and you can see the deep sulcus, the sharply defined costophrenic angle there. Here, what happened? Air has collected under the lungs. So you're actually seeing the undersurface of lung clearly outlined. So there is air between the undersurface of lung and diaphragm. This is again how pneumothorax can appear on supine X-ray. Okay. So now we are going back to the quiz.
Thank you.
Over to you,
Dr. Sujit.
Sadia.
And hopefully you can see my mouse moving on the screen.
I have
Or
given you
maybe
control,
not.
but I can see the mouse. Would you like?
Yeah. Oh, can you see it now?
Yes, yes. Yeah.
Yeah, great. So we'll go over the first question. I was reading through the chat. I think a lot of you got it correct. So it is a right pneumothorax, as you can see here if you follow my cursor. So one of the things to remember, as Dr. Sujit was just explaining, is that it will have a sharp, thin, white pleural line separating the air in the pleural space from the lung. And as you can see, peripheral to this, there's an absence of lung markings. So those are your two features to identify a pneumothorax. Now the next case. So this was a left-sided tension pneumothorax. Now if you can see here, don't know how visible it is to everyone.
Oh, give me one moment. I think accidentally the slide moved. Let me move back. Yeah. So this was the.
Yeah. So over here, as you can see, there's the collapsed lung outlined over there. And then you can see the signs of tension. So number one being the depressed left hemidiaphragm. And then also the mediastinum has shifted to the right-hand side. So mediastinal shift to the right would mean left-sided tension pneumothorax. And you can see the trachea here as well that shifted to the right-hand side. And management for this, for those of you who answered, is immediate needle decompression. And now the next case. So is this a normal chest X-ray? No, it's not. This one is a bit more difficult to see. So there's a right-sided pneumothorax. And if you can see here, so here we've got the scapula.
Oh, sorry.
Oh, sorry.
I'm just moving back.
No, that's fine. Here you could see the scapular border. And then over here, if you can follow my cursor, there's the pleural lining. So that's right-sided pneumothorax. And I'm not sure how clear the image is for everyone, but there are lung markings that are absent peripheral to this as well. And so if we go on to the next one. And as Dr. Sujit was saying, there are mimics of pneumothorax. So over here, this is actually not a pneumothorax. This is a skin fold in a chubby baby. So there's a band-like density as opposed to a crisp thin line. So a crisp thin line would point to it being pleural, and the band-like density means that it's something more superficial, like a skin fold. So the point here to consider is number one, it's not crisp. And number two, as you can see, there are lung markings peripherally to this as well. So there's no pneumothorax here. And now the next one, again, not sure how many people got this. It's a bit more difficult to spot, but never forget to check your apices. So here we have a left apical pneumothorax, if you can see over there. And again, it's a crisp line, so there's a small but definite left apical pneumothorax.
Just to add on to this X-ray, so these kind of pneumothoraces, the last two ones, it's very likely that we may miss them if we don't look for them. So it's important to look for small pneumothoraces. So it may not be obvious if we look carefully, a line that is separate from the rib outlines here, like a thin white line, without any lung markings beyond. Okay, so that is a apical pneumothorax. So these X-rays are the type that can be kept for exam in a radiology exam. But when you start as junior doctors, it's important that you know this and you are able to pick them up, because you are managing your patient, not writing an exam. Okay, so moving on. Okay, I'll take it from here.
Thank you.
Thanks, Adya. And so just a brief mention about two normal appearances, one normal appearance. So this is the cardiophrenic angle. This is what we call as the cardiophrenic angle here. Cardiophrenic angles in some X-rays which will have pericardic fat. Pericardic fat pad will give a hazy appearance, not a very dense appearance what you are seeing here. Okay, so get your eyes used to this appearance. So this is not pathology. This is because of pericardic fat. You should not mistake it for an abnormality, abnormal soft tissue mass sitting there or pleural fluid or anything. So this is just to draw your eyes to a normal appearance of pericardial fat that you'll see at the cardiophrenic angles. Now, moving on, the other abnormality about pleura is about pleural plaques. So you must have heard about calcified pleural plaques or non-calcified pleural plaques. They usually occur in the setting of previous exposure to asbestos. So calcified pleural plaques, they will look like how you're seeing here. So their favored sites are the costal pleura and the diaphragmatic pleura. So you will see well-defined map-like or geographic map-like or amoeba-shaped irregular opacities, calcific opacities overlying the hemithoraces because these are over the costal pleura. You will also see clearly calcified plaques overlying the diaphragm. Okay, so once you see this, you are inferring that the patient has had previous exposure to asbestos. Now, having pleural plaques does not mean that you are having a disease. It is only a sign of previous asbestos exposure. These are not pre-malignant. They are not going to change and turn into something more sinister. No. You don't need follow-up X-rays or follow-up imaging just to monitor pleural plaques. So they are just an indicator. A patient having pleural plaques, if he develops any symptoms, any exertional breathlessness or chest pain, then the reason for that is something different that you have to investigate. But pleural plaque as such is not going to cause any symptoms, or it's not pre-malignant. It doesn't require any monitoring. Okay. So that was just to commonly seen chest X-ray findings. Just wanted to for you to know how they appear. So these are usually well defined and map-like a geographic pattern. Okay, so that is how we identify it as a pleural plaque. Now we come to the last session. So there is a quiz for you, and over to you, Zain.
Thank you very much, Dr. Sujith. So another couple of questions for everyone. Starting off with, what is this region called? Okay, next question. I think we've skipped a question. A 50-year-old woman presents to you with a 4-week history of progressively worsening shortness of breath. On examination, her respiratory rate is 18 breaths per minute, pulse is 85, and her other parameters are within normal limits. A chest X-ray is performed which shows We'll move on to the next question. A 67-year-old presents with a 4-week history of progressively worsening shortness of breath. Observations performed are normal, apart from a mild tachypnea. Clinical examination reveals dullness to percuss in the right lower base. What is abnormal on this X-ray? We'll move on to the next question. And finally, what is the abnormality on the right side of this X-ray? I'll now hand over to Dr. Sujith to continue with the
Thanks,
talk.
Thanks, Zane. We'll just continue with the teaching part. So we are looking at pleural effusion now, okay? So pleural effusion means like how we saw pneumothorax was air collecting within the pleural cavity. Now we have fluid collecting within pleural cavity, and that is pleural effusion. It can be a transudate, like when the protein content is less than 30 grams per liter, or an exudate when it has higher protein content, okay? So on an X-ray, they are all going to look the same, okay? So even if it is clear fluid, thick fluid, if it's blood, if it's lymph, anything would look same, okay? So these are some causes for effusion. So the transudate causes are the three failures: the renal failure, heart failure, liver failure. Exudates usually in infection, inflammation, infiltration, infarction, etc. Okay, so we just move on to the radiological features. So we get blunting of costophrenic angle. So usually we need the costophrenic angles to be sharply defined. We'll get blunting of cardiophrenic angle when the volume of fluid goes up. Fluid may go into the horizontal or oblique fissures. Why? Because we've seen that the fissure is formed by invagination of visceral pleura alone. So the pleural space just continues into the fissures. With a moderate effusion, you will usually see the lateral aspect sloping up gently, okay? So that is called meniscus. So on a pleural effusion, it will slope up towards the chest wall, okay? With even larger effusion, because of the volume of fluid, it will push mediastinal structures away from the effusion. Now, hydropneumothorax is when there is both fluid and air within the pleural cavity. So when there is hydropneumothorax, that will take off the meniscus and will result in a horizontal air fluid level. So that is how we say there is hydropneumothorax. Okay, so we're looking at a few examples. So look here, we've got a sharply defined left costophrenic angle. And here we are seeing blunting or obscuration of the right costophrenic angle. So there's a small effusion. So remember, when we discussed the anatomy of pleura on the lateral image or from the side view, we saw that posteriorly, the pleura dips even lower down. So when small volume of fluid, say 50 ml fluid collects in that most dependent part, you are not going to see that on a chest X-ray. For the lateral costophrenic angles to become blunt, so you need more fluid, around 175 to 200 ml for the right costophrenic angles to become blunt. Larger volume of fluid will go will cause obscuration of the dome of diaphragm and the cardiophrenic angle as well. Okay. So here there is a 56-year-old male with new onset dyspnea. What you're seeing here is a larger volume of slightly bigger effusion than from what we have seen previously. Okay, so possibly this is not fully included the left costophrenic angle, but possibly the costophrenic angle on the left is obscured as well. Now we have got a bigger size effusion, and here now you can see a moderate effusion with a sloping meniscus. So this is meniscus size, and you see that in all pleural effusion, which is of a moderate size and which doesn't have any associated pneumothorax component. Okay, so now we have a case of pneumonia. So there is consolidation here in the lung that has resulted in an associated pleural effusion. And again, you are seeing the meniscus sign here. So moving on. Now coming on to hydropneumothorax. Okay, so this X-ray, this patient has some abnormality in the right lung upper lobe. Forget about that. We are focusing only on the left hemithorax. You can see a large volume of air here. This is free air. You're not seeing any lung markings. The left lung is sort of collapsed. And at the bottom, you're seeing a horizontal level, and the costophrenic angle is also obscured. So this is a air fluid level, horizontal, and that is in keeping with the hydropneumothorax. Now we have a large effusion here, a massive effusion, which has resulted in whiteout of the entire left hemithorax. So there is whiteout of the entire left hemithorax, and that has resulted in obvious shift of mediastinum towards the opposite side. Okay, so this is a massive effusion with mediastinal shift. So we're coming to what we call as encysted effusion. So this is what we discussed earlier. There is fluid which is loculated within the right horizontal fissure. On an AP view or a frontal view, PA view, it would look like this. And on a lateral view, this is how it is going to be seen. Okay, so it is between the two layers of visceral pleura, right? So this can happen in heart failure when there is a pleural effusion and then fluid loculates within the horizontal fissure or oblique fissure or whichever fissure. It might look to you there is a lesion there, a tumor there, or an abnormality there, and then you treat heart failure, you give diuretics, and you repeat X-ray, it would have disappeared. This fluid also would have disappeared, and that's why this is called a vanishing tumor. Now, this is an X-ray which, let me see if anybody has any comments, any thoughts, what this could be. This looks very different from the pleural effusion that we have seen so far. Very good. So there's an answer, supine pleural effusion, right? That's very good. Impressive. Very good. So just like how we saw how pleural pneumothorax has a different distribution on a supine X-ray, on a supine film, pleural fluid also distributes differently. So it's a bit harsh on you because I don't think I can see the mark supine on this X-ray. So, so this is effusion on a supine X-ray. What happens actually is when there is a moderate effusion, when the patient lies down, fluid will gravitate down between the posterior pleural layers. So give some time and the fluid will gravitate down to the posterior pleural layers. So when the X-rays pass through anterior aspect, it's going through the air-containing lung and then through the fluid in the posterior aspect before it falls on the receptor, X-ray receptor. So that's why we're not getting a dense white kind of effusion here because the X-rays have passed through air-containing lung before going through the fluid. Okay. On an erect position, when you're taking an X-ray, there is fluid both in the anterior pleural space and the posterior pleural space, which adds to the density. So this is an appearance that will give a hazy appearance to the hemithorax, but you are very well clearly seeing the domes of diaphragm, the mediastinum, etc., and nothing else would explain this picture. Okay, so pleural effusion should have looked very dense. So when it's not like this, you may not be thinking along those lines. So interrogate again and see, could it be pleural effusion in the supine position? This doesn't fit with pleural effusion. This doesn't fit with a consolidation where again, it should have obscured the lung, underlying lung, and it should have taken away the borders of the mediastinum and diaphragm. So nothing else fits with this. This is pleural effusion in the supine position. Okay, so pleural fluid layers out in the posterior part of pleura. Hemithorax will appear whiter or hazier than the other side. And through that, you are seeing all the normal lung markings, which will not happen if there is a consolidation or a collapse or any other lung pathology. Okay, so these are clues. So through this haziness, you are clearly seeing the lung markings. So that is the clue to say this could be an effusion in the supine position. We're going back to the quiz now. Over to you, Zain. Yeah.
Yep. So I've requested access. Can you see my mouse or the cursor?
Yes, we can.
Yeah. Okay. So in this question, we asked, what is this region called? So Dr. Sujith went through the landmarks on an X-ray, and this is the right costophrenic angle. And I think a lot of you guys got that in the chat as well. So moving on to this question, we can see that the answer is D. A large left-sided pleural effusion can be seen. We can also see the classic meniscus sign that is associated with pleural effusions. Despite its size, we can see that there's not much mediastinal shift that's associated with this pleural effusion. And I'm pretty sure a lot of you guys, again, in the chat got the correct answer, so well done. And in this question, what is abnormal on this X-ray? Well, we can see a right-sided pleural effusion on this X-ray. A lot of you guys picked up on this, but I'm not sure if anyone picked up on these markings here. So these are sternotomy wires, possibly due to some sort of operation that was done on this patient. Can we have the next question, please? And finally, again, a lot of you guys, well done for getting this. This is not a pleural effusion. We can't see the classic meniscus sign. Instead, this is a right hydropneumothorax. We can see that this is an air fluid level as it's nice and flat. And it's also associated with the collapsed lung on the right, which we can see here.
Zain, we cannot see the cursor.
Oh, my cursor has disappeared. Whoops, apologies.
Sorry. Yep.
Here
Yep.
you go, sorry. We can see that this is the collapsed lung on the right-hand side, and we can see that this is not the meniscus sign that's typically associated with pleural effusions. Instead, it's an air fluid level. So this is why it's a right hydropneumothorax. I'm not sure if you saw my cursor last time, but these are sternotomy wires in the center as well. So I think that concludes the question, so I'll hand it over to Dr. Sujit.
Thank you. Thank you, Zain. So that brings us to the end of the first session of the series. So we looked at the technical factors, which include the markers, the rotation, whether the patient is centered or not, the adequate inspiration or not, and the degree of exposure. And then we looked at the anatomy of pleura, and then we covered two pathologies, pneumothorax and pleural effusion, including how they would look on a supine position X-ray. So I hope this has been useful for you, and please do send us feedbacks. This is the first first session of the series, so feedbacks are very important for us. So thank you very much. So let me go through the chat. If there are any questions that you would like me to answer, I can go through them now. Yes, certificates will be provided at the end of the session once the feedback forms are received. So are there any further questions that we can see?
Thank you very much, Anjali and the team. Next section, Anjali, the next session is next week, correct?
Next week, Friday, same time, 6 to 8.
Right. So, and what are we teaching next week?
Next week, it will be trachea, heart and mediastinum, and lung hyla. So these are important topics.
Excellent. So, very important topics next week. So, thank you for attending, and we hope to see you again next week. And this will be again 1800 hours, Anjali?
That's right. Yeah. Starting
1800 hours
1800.
GMT.
Yeah, GMT. 2 hours.
Excellent. So we will be waiting for your feedback also. And if you need anything specific in radiology, of course, we are going to teach you whatever is required according to the new curriculum and the MLA, etc., pneumothorax, pleural effusion. We know what to teach in chest, abdomen. And please remember that CT brain, particularly vis-a-vis hemorrhage, that should be known to all medical students. So we will teach that also. Anything specific you need, please, you can write down in your feedback forms. So from my side, it is, can we display the, still display the feedback slide,
Oh,
the
yes.
QR
Yes.
code slide, QR
Yeah,
code
yeah,
slide.
we'll do that. Oh, sorry, did I come out of the?
Yeah. Now I can see it. Just put it here.
Yeah.
Okay, then all of you, the QR code slide will be up for the next 5 minutes, and we expect to, you know that to get the certificate, attendance certificate, it is mandatory to fill up the feedback form, and you will automatically receive the attendance certificate. Thank you from my side, and good night.
Thank you, Dr. Khan. I'm just turning my video off for some time.